Is Claire McAndrew with Families USA. Claire, over to you.
Thanks so much, Janelle. People see my screen okay? I'm Claire McAndrew from Families USA. We are a national nonprofit, nonpartisan organization dedicated to the achievement of high-quality, affordable health care for all. And so today I'm going to focus on some protections that are already in place and some future protections in the Affordable Care Act that will make access to care and coverage easier for people with hemophilia. So to kick us off, I'm going to go over the Affordable Care Act in a nutshell, basically 4 of the broad categories of health coverage protections that the Affordable Care Act provides. So first of all, the Affordable Care Act reforms the private insurance market, the market where if you buy coverage on your own from an insurance company or if you get coverage from your employer, that's where you're getting your coverage, from private insurance companies, and there will be new consumer protections in that market. The Affordable Care Act also creates new marketplaces, which you may also hear referred to as exchanges, where people, individuals, families, and small businesses can go to purchase coverage, and some will be eligible for financial assistance based on their income. The Affordable Care Act also expands the Medicaid program, the coverage program for low-income people, and then finally it strengthens Medicare, which offers coverage to people 65 and older, as well as people with permanent disabilities. And it strengthens Medicare by increasing benefits, covering preventive services with no cost sharing to enrollees, and also closing the gap in drug coverage that is referred to as the donut hole. By 2020, there will no longer be a gap in coverage in Medicare for prescription drugs. That donut hole will be closed. And I should say these are really the provisions that relate to health insurance coverage in a nutshell. The Affordable Care Act also has many provisions that relate to the way we pay for and deliver care to improve it and make it more efficient, as well as many public health-related provisions. But today we'll be focusing on health insurance coverage. And so many of the protections in the Affordable Care Act actually already took effect. So I'm going to go through some of those and then talk about what the Act will do in the future. But to start off, the Affordable Care Act implemented a ban on lifetime dollar caps in coverage. And this is a barrier that I've actually heard most often described as a problem for people with hemophilia. If somebody has the expenses of the clotting factor, they might hit, say, a $1 million cap on coverage easily, not over the course of their lifetime, but much more quickly. And so I've even heard those stories, as I'm sure you have, of people having to switch jobs because they, quote, run out of coverage. So that type of practice is no longer permitted for insurance companies. They can't say we will only cover $1 million of care over your life or $2 million of care. There can't be that kind of limit. For a similar limit that takes effect each year, so say a plan that says we will only cover $500,000 worth of coverage a year, if you hit that limit, you basically have no coverage until the year starts again to the next year. That type of practice will be prohibited in 2014. Also in effect now is a protection that insurance companies can't refuse to cover children with pre-existing conditions, defined as people up to age 19. Of course, young adults can stay on their parents' plans until they turn 26 years old. This has been a very successful and popular provision of the law. And certain preventive services must be offered free of charge to consumers who are in plans that were sold after the law passed in March of 2010. So services like different cancer screenings, different vaccinations, contraceptive and other women's health services, as well as smoking cessation services, all must be covered free of charge in plans that were sold after the law took effect. Also in effect now is a protection against insurance companies doing what are known as unfair rescissions. And so this happens when an insurance company already has a person enrolled in their plan, but say that person needs some expensive medical care, and some expensive claims are filed. At that point, the insurance company might look back in that person's medical records, really seeking out medical care, whether it was a doctor's visit or a prescription drug, that that person had in the past but didn't report when they applied for coverage. Now, of course, if somebody didn't report a significant illness, that would be quite fraudulent. But if somebody forgot to mention a certain specialist they saw 1 or 2 times, or a certain drug they took out of being forgetful and not realizing that that's important, the insurance company might still say to that person, you never told us you had this service. If we knew this, we never would have offered you this policy. Your policy is fraudulent. We're canceling you. In fact, sometimes they actually say you have to pay back everything we ever covered you for. It's a really egregious practice. There's been some instances, for example, in California, there was a case of an insurance company doing this to thousands of people. So a really abusive practice that's now prevented by the Affordable Care Act. Now, if an insurance company claims that a person committed fraud on an application, that person is given advance notice of the potential rescission, that person is given a right to a hearing to defend their side, and it is on the insurance company, they bear the burden of proof that intentional fraud was committed. So it really strengthens the protection for consumers. The law also has in place now a right to both internal and external appeals in any plans that were sold after the law was passed. So this is an important protection when you're in a situation where your doctor says you need a certain service, and they file a claim with the insurance company, and the insurance company says, no, this is not medically indicated, or no, this is experimental for your situation, we're not going to cover it. What this law says is you have the right, first of all, to appeal with the insurance company. So you're basically asking the insurance company to pull in its medical experts and revisit the decision to see if there was an error. If at that point the insurance company still says, no, we're not covering this, you then have the right to an external appeal. And that's with an independent body of medical experts whose sole role is to conduct these types of appeals, and they will objectively review your case. And if that external appeal body says that you do need that type of service, the insurance company is legally required to provide it. It's binding. So before the Affordable Care Act, many states did have protections like this, but it was a patchwork across the country. So you might have a state that has the internal appeal right, but not the external right. Or here in the District of Columbia, we had the right to appeal to an external body, but it wasn't binding. So they might tell the insurer, yes, you should cover this, and the insurer could say, no thanks, we're not interested. Obviously, that wouldn't really help the consumer. So now it creates a uniform protection nationwide. And then finally, another protection in place now is the pre-existing condition insurance plan. And this was an insurance program that was created to serve people who can't get coverage elsewhere because of their health conditions and who have also been uninsured for at least 6 months. And so there are many people enrolled in this program. However, it did have limited funded appropriated to it, so it recently has been closed to new enrollees. So only people who are currently in the program are continued to be served through it. However, that was meant to be only a bridge program because in 2014, we no longer need a separate program just for people who have pre-existing conditions. And that's because every insurance company has to include all their applicants regardless of their health status. People will no longer be able to be turned away because of their pre-existing conditions, and insurance companies can no longer sell policies that cover everything except someone's most important health condition. Right now, you might get an offer of a policy that says, sure, we'll cover you, but we're not going to pay for your clotting factor. Or, sure, we'll cover you, we'll cover your child, but your child has asthma, so we're not going to cover your child's respiratory system. That type of practice will be prohibited in 2014. Similarly, you can't be charged extra because of your health status. Premiums won't be set based on how sick or healthy you are. You also can't be charged more based on gender. For many years, women have been charged more than men for coverage, and that will no longer be allowed. And then other factors for which differential premiums have been allowed, such as age and tobacco use, will be limited. So now we'll often see older people being charged 5 or 6 times more for coverage than younger people. Under the Affordable Care Act, there's a cap that says the differential can be 3 to 1, but no more. And then for tobacco use, the differential can be 1.5 to 1. And I will say that Families USA has been concerned even about that differential for tobacco use, and as well as some of our partners like the American Cancer Society and the American Heart Association, because there isn't evidence that charging tobacco users more for coverage will actually get them to quit smoking. However, what it will do is make coverage unaffordable, and we're worried about that because we achieved an important win in that cessation services must be covered by insurance now, and all these proven evidence-based ways to help people quit smoking will be covered by insurance plans. So we don't want to see people priced out of that coverage and not have access to those services. So Families USA has actually worked with a number of states and our state partners to look at having various states not implement any differential, because states can always implement these rules in a way that's more protective of the consumer. These are caps on how much coverage can cost. So also in 2014, plans that are newly sold, or really that were sold anytime after the health care law passed, are going to have to start covering what's known as the Essential Health Benefits Package. And this is a list of 10 categories of services that were outlined in the law that all of these plans sold to individuals and small businesses must cover. So the services range from ambulatory or outpatient services, emergency and hospitalization, as well as maternity care, mental health care, prescription drugs, which I know is very important for the hemophilia population, as is rehabilitative and habilitative care. That's where you'd see your physical therapy benefits, laboratory services, prevention and wellness services, as well as some specific services for children, including oral and vision services. So in addition to these protections that will apply in the market where individuals and small businesses buy their coverage, there's also a new specific marketplace where people and businesses can shop, and this is the marketplace that's also known as the exchange. And the exchange is providing important new tools to consumers because it's finally bringing some clarity to health insurance options. Right now there's a lot of jargon, there's a lot of fine print when you try to understand a policy, but in the marketplace, all the information about different health plans will be presented in a standardized format with easy-to-use language. The marketplace is also where people will go to apply for financial assistance based on their income to afford coverage. The marketplace is often referred to as a one-stop shop. That's because it provides seamless access not only to private insurance, but to the Medicaid program for low-income people, as well as for those subsidies to make coverage affordable, which we'll talk about more in a minute. Consumers also are guaranteed the right to assistance to get their questions answered when they're shopping in the marketplace. And you'll know that the coverage you get in the marketplace is of high quality because every plan in the marketplace has to meet certain specific standards for consumer protection and quality. So I'm going to talk about all of these aspects of marketplaces. But first, I just wanted to talk a little bit about who is in charge of the marketplace, because I feel that this has been an issue where there's been a lot of dialogue in the press about who is running these marketplaces and will they be run on time and who's in charge. So basically, the vision of the Affordable Care Act was that every state would run their own marketplace. However, if a state did not do so in time or did not want to run their marketplace, the federal government could run the marketplace on behalf of that state. And then there's also a third option where the federal government and the state together would jointly run the marketplace. So if you look at the slide that's on display now, you can see your state and see what kind of marketplace you have. The states that are darkest blue are state-run exchanges. Those that are gray are federally run exchanges where the federal government will be operating the marketplace on behalf of the state. And those few states in light blue are doing a partnership model. But what's important to know for consumers is that regardless of who is in charge of your marketplace, you are guaranteed the same rights, the same access to coverage, the same easy-to-use tools, and the same access to financial assistance with coverage. So in the marketplaces, if you earn up to 400% of poverty, which is just under $46,000 for an individual and just over $94,000 for a family of 4, you are eligible for financial assistance to afford. And this financial assistance comes in the form of premium tax credits. However, these are advanceable credits, so you don't have to wait until the end of the year to file your taxes to get this assistance. It can be advanceable so that the assistance goes directly to the insurance company so that when you get your bill for premiums, it's lower than it would have been otherwise. If you earn up to 250% of poverty, which is just under $29,000 for an individual and just under $59,000 for a family of 4, you can also receive additional assistance to make your cost sharing, your co-payments, your deductibles more affordable for you. And then finally, if you earn an income of 138% of poverty or below, which is just under $16,000 for an individual and just over $32,000 for a family of 4, you will be eligible for the Medicaid program that provides coverage to low-income people. However, there is a caveat here. The Supreme Court decision that we received last summer made it optional for states to expand the Medicaid program to this level. And so basically our top priority at this point at Families USA, an organization that's focused on bringing affordable coverage to low-income consumers specifically, has been to encourage states to expand this program because it's such a critical option for people who really can't afford almost no insurance premiums. And you look at the private market, coverage is quite expensive, and so people really need this program, and it's been a key advocacy priority for us. But so when you do go to the marketplaces, starting on October 1st, you fill out just one application. And that one application will tell you, are you eligible for Medicaid? Are you eligible for that financial assistance to make your coverage more affordable? Or maybe your income is so high that you don't qualify for assistance, but you can still be deemed eligible to use the tools of the exchange and shop for coverage in the marketplace. And I want to clarify that you go on the marketplace starting on October 1st, and that's when you can start shopping. But the coverage actually takes effect January 2014. And the reason it's such a good thing that you can start shopping October 1st is that we want to make sure people have ample time so that when coverage takes effect in January, they're enrolled and ready. It's a new process for many people. They won't have used a marketplace before. Many people will never even have had health insurance before. So we want to give people ample time to get their information ready, to be able to report their income, and to go through this process so that when the coverage takes effect January 1, they have their card in hand and are ready to go. So people, as I've mentioned, can apply online for coverage, but the Affordable Care Act recognizes that not everyone uses the Internet. So people can also apply by phone as well as in person with different assisters that I'll talk about in a minute. So once you go through this application process, you find out what program you're eligible for, and that's when you would start, assuming you're not eligible for Medicaid, comparing your different insurance options, and then you can actually roll in and plan through the marketplace. But as I mentioned, it's not up to people to figure this out all on their own. People are guaranteed the right to a toll-free call center that can answer their questions and can actually also help them fill out the application for coverage. And people can also go to trained and certified assisters to walk them through the process. And there's 3 different kinds of assisters. The first are the navigators. And these are entities that were outlined in the law designed to be people and organizations that have experience serving the populations that will likely be eligible for coverage through the marketplaces. They have to comply with strict conflict of interest rules, so they can't be an employee of an insurance company or an insurance broker because they have to provide unbiased information. They can't have a financial stake in what health plan you choose. They get grants from the exchanges to perform this work of helping people walk through the process, and they also have a responsibility to do outreach and education in the broader community to make sure people know about the coverage programs. In-person assisters are actually a very similar entity. They perform that same role of walking people through the application process, but really their main difference is their funding source and the intention of them to be really building up capacity in the early years. When the exchange first opens, it's sort of a cadre of people recognizing that we'll have a ton of new applicants to fill that extra capacity needed early on. But their role will be very similar to navigators, and they too won't have any conflicts of interest. And then finally, there are certified application counselors. These are the entities that are already helping people, say, apply for Medicaid or other benefits. They can go through a program to get certified as also an expert enroller for the marketplaces. So they complete a training program that's similar to what the navigators complete, and they become certified to not only help with the programs they already help with now, but also to help with the new marketplace coverage. So what do you get when you actually get insurance through the marketplace? The insurance you enroll in has to meet a number of set standards that are outlined in the Affordable Care Act. And that includes all of the standards we already talked about for private insurance, as well as standards relating to having a sufficient network of healthcare providers. That includes essential community providers that have served predominantly low-income, underserved individuals. They also have to have their provider directories easily accessible to consumers and up to date. They can't use marketing practices that are discriminatory. They have to be accredited by national recognized quality accreditation organizations. They have to report on their quality in a user-friendly way so that consumers can learn which health plans have the best success in securing timely access to care for people, to having good outcomes for people. And they have to submit to each marketplace their plans for improving quality each year. So I'm going to focus specifically on the provider network standard because I think that's particularly important for people with hemophilia and those who work with them and on their behalf. So the law says that any health plan sold in the marketplace must have a network that is sufficient in both the number of healthcare providers and the types of healthcare providers. And these providers and the services they provide must be accessible without unreasonable delay. And this includes essential community providers. I mentioned before that these are defined as those providers that serve predominantly lower income and underserved individuals, but it also includes a lot of different types of specialized safety net providers, and it actually includes the hemophilia treatment centers, as well as safety net clinics, federally qualified health centers, safety net hospitals, family planning clinics, etc. So the law says that where those types of providers are available, they have to be available in the plan's network that's in the marketplace in a sufficient number and provide timely access to those providers for consumers that are enrolled in the health plan. So there are many ways that a state could implement this federal requirement. The state could just say, hey, health plans, federal law says you have to have these providers in your network. Sign on the dotted line that you have enough of these providers. So that's one way you could do it, but as consumer advocates, we want to make sure that this law and this guaranteed right really is materialized for the consumer. So we took a look at various states and how they're implementing this protection. So I want to tell you about some of those states. One consumer-friendly way to ensure you have enough essential community providers in your network is to implement what is called an any willing provider standard. So for example, in Minnesota, the health plans that will be in the marketplace have to at least offer a contract to all essential community providers that are in their service area. So they would have to say, Hemophilia Treatment Center, would you like to be in our network? Here's the contract we can give you. Now, of course, if for whatever reason the Hemophilia Treatment Center doesn't want to be in their network, they don't have to be, if they don't take insurance, which I think most of them do. But if they don't like the terms of the contract, et cetera, they don't have to be in every network, but they can't be excluded. They at least have to have an offer. States have also looked at setting a threshold, so saying, for example, in Connecticut, any health plan that's in the marketplace has to have at least 75% of essential community providers that are in the county in their plan's network. States have also looked at requirements for contracting by category. And I think this is important because even if you had 75% of the essential community providers in your network, what if that left out key essential community providers like the Hemophilia Treatment Center? That would be very concerning. So under this type of model, you would say you must have at least one safety net hospital, at least one Ryan White HIV/AIDS provider, at least one Hemophilia Treatment Center in your network. And so the federal exchange is sort of getting there in their standards, that the exchange that will be operated in states that elected not set up their own exchange, they say, one, you have to have at least 20% of essential community providers in your network, but two, you must show that you have at least one essential community provider from each of various categories in your network. However, I am a little bit concerned because the hemophilia treatment centers fall into the other box, and so other includes hemophilia treatment centers, STD clinics, and other entities. And so that's why I'm going to talk in a minute about steps that people on the webinar and the Hemophilia Federation's colleagues can all take to make sure that these centers are included in the networks of the health insurance plans that will be sold in the marketplace. And so that's where I get into my last slide about getting involved. I think that hemophilia treatment centers tend to be pretty savvy about making sure they're in networks, but if you know of a treatment center or any other provider that's been really essential to consumers with hemophilia in your community, you might want to reach out to those providers and say, are you aware of opportunities to contract with the plans that will be in the marketplaces? Because again, those are the plans that people will be able to afford with subsidies. They're going to be enrolling a lot of consumers who may have struggled to get insurance before. So you can talk to them. And actually, let me go back to this last slide about being in those networks. And I wanted to point out this last slide. There is a resource linked at the bottom, and that's the resource that the federal government created. It is a non-exhaustive list of essential community providers in each state. So any safety net provider or clinic that you think is really essential to be in the network, you want to check if, like, for example, those hemophilia treatment centers are on that list. And if you see essential center that's not on there, you can email the contact information for the federal government that's posted at the bottom and let them know you think that it should be on that list. But it may be even better to also tell that provider, hey, you better email to get on that list. When it comes to providers that aren't defined as essential community providers, so just a key trusted specialist, you might also want to talk to them just, do you think that you're going to be included in the network of these plans that are on the marketplace? We think it's really important. Because unfortunately, there's a lot of misinformation among healthcare providers about the Affordable Care Act. And so you want to make sure that they're not hearing negative rhetoric, but instead are actually involved in the plans that are going to help consumers. I also think it's really important for anyone who is educated about the healthcare law to get involved in spreading the word. October 1st is a really important date in that people who before couldn't get coverage because they couldn't afford it or because they had pre-existing conditions can start applying for coverage that they will be eligible for, and that will take effect in January. So getting the word out is really important. And then finally, once the marketplaces are up and running, it's also important to report any problems. We know from experience, for example, when Medicare started its prescription drug benefit, Part D, that when you start a really big program like this, inevitably there's going to be glitches. There's going to be bumps along the road. The most important thing is that people know about those bumps. The people who can fix them know about them. So if you do see problems, if people's applications aren't going through, if people can't get access to the health plans they want to enroll in, if the networks aren't sufficient, it's important to report those problems not only to the marketplace in your state. Every state marketplace will have a website that will have contact information on it. But you can also report it to the Hemophilia Federation, to Families USA, to groups that are invested in trying to make sure the law works for consumers. So you can always reach out to me. My contact information is on this slide. And you can reach out to me not just about reporting problems, but also if you have questions. And then I posted 3 resources on this slide. The first is a link to a report that we wrote at Families USA that just goes through some examples of how different states are implementing the protections in the law in a way that can really give teeth to those protections, sort of what we talked about with essential community providers. The second resource is a really easy-to-use fact sheet about the different types of in-person assistance that will be available, the navigators, assisters, etc. And then finally, the last piece is something that you might want to share with hemophilia treatment centers or other essential providers in your community. It's tips with how providers can make sure that they're connected with the health plans in the marketplaces and in those networks. So I'll wrap up there, and then I'm really looking forward to any comments and questions you all have.
Thank you so much, Claire, for that very informative presentation. We will now open up the line for questions. Available on the HFA website.
You did.
Call back about 10 minutes. I'm on a webinar. Okay.
Do you folks have questions?
Okay, first we're going to start with Sue. Your question, please.
Apologies, no questions. Thank you.
Okay. Do we have a question from Anil?
Hi.
It will be on the HFA website. If you do have any questions at this time, send those questions and we will make sure that they are answered on the website. I think there is a question. Question is the financial assistance only available to people in the exchange, or is it available for private insurance too?
So the exchange offers private insurance. Basically what the exchanges are a new way of delivering the same type of coverage people are used to now in a more transparent environment. So we've already seen various states around the country listing out which insurers have indicated they will be participating in the exchange. So for example, in California, it's 13 major insurance companies will be selling their insurance plans through the marketplace. So I think it's important for people to realize not that it's a kind of coverage. It's still private insurance. It's just a portal to private insurance that we didn't have before, where you can go to one place and find out about every plan in your state, and you know that those plans are being well regulated so that we're not having any sort of consumer abuses. But you still get the same type of coverage you would get in the private market now with some additional protection. So to answer your question, yes, you must use this exchange portal to access the financial assistance, but the type of coverage you'll get is very similar to the coverage that's available now, hopefully a little bit better, but it will still be from your Blue Cross, your Aetna, your United, as well as hopefully some new companies that are focused on driving quality.
Copy of this presentation, along with there's narrative notes. So that question is yes. Please contact the HFA office. Check with the website first, but if that isn't sufficient, you can contact me directly.
And it will also be available to watch again on the website if there are any little things you missed and want to hear again.
The next question is, I am on a group insurance plan that covers Factor for my kids, but the premium is very high, increasing at 50% every year. What is the risk of not getting a Factor coverage if I bought a plan on my own?
So to start off, if you are in a group plan, if you get coverage from your employer and that coverage isn't affordable for you, if that coverage ends up, there's actually a threshold in the law. If it costs more than 9.5% of your income, you can leave that coverage and apply to get financial assistance for coverage in the marketplace. Now, the coverage of clotting factor as well as other drugs could vary by state because each state sets up a benchmark plan to be the basis of the coverage that every plan in the marketplace must provide. And so states have chosen their benchmark plans, and those plans, of course, have certain formularies. So I think my advice is to definitely check. Once the plans are posted in October, you would want to carefully check the formularies and coverage for factor and other important services that your children need. You'd want to review those plans and make sure that you know what they cover, certainly before buying one. And you'd also want to compare different plans because just because a plan doesn't have to cover a certain type of drug or a certain brand of drug, doesn't mean they won't cover it. The plans have different formularies, so you'll want to carefully check. I would say as a third step, if you're in a state where unfortunately there is a lack of adequate formularies for factor, I think that's when you start making calls. You contact the marketplace, you tell them the coverage is insufficient, and you also work with partners like Hemophilia Federation so that we can continue that advocacy going forward. But I do anticipate that the coverage for factor is going to be quite similar to the coverage for it in different private insurance plans right now, in which I think probably everyone on this call has been involved in advocacy over time to improve those formularies, and that'll be an ongoing effort. But basically, it's always just important to check documents. It'll be hopefully easy to understand now that they're going to be standardized. Before selecting a plan, you really want to check that formulary.
Okay, that seems to be the end of the questions. If you have any other questions, please contact HFA. Phone number is 800-230-9797. All for joining us today. Have a great rest of your day.